lecture series, and this is going to be the acquired retinal disease part 6, and in this part we are going to discuss about the choroidal neovascularization. So choroidal neovascularization, as the name suggests, indicates that there are new vessels formed in the choroid. Choroidal introduction. Choroidal neovascularization CNV consists of a blood vessel complex that extends through the book membrane from the choriocapillaries into the sub-RPE type 1 or subretinal type 2 space. So there are two types. If the choroidal neovascularization extend up to the RPE, like it's beneath a RPE, it is known as type 1, whereas when it extends between the RPE and the neurosensory retina, it is known as a subretinal CNV, and it is known as a type 2. It occurs in many different disorders, usually when the Bruch membranes and or RP functions has been compromised by the degenerative, inflammatory, traumatic or neoplastic process. So these can occur whenever the Bruch membrane and RPE function compromised by the degenerative, inflammatory, traumatic and neoplastic process. AMD is the most common causative association, followed by the myopic degeneration. So first cause most likely of the CNV is AMD, next is the myopia. The present discussion relates to the CNV arising de novo as the primary lesion in the neovascular AMD, but the CNV may also develop secondary to retinal angiomatous proliferation and polypoidal choroidal vasculopathy. So basically, right now we are discussing CNV, which is arising without any disorder, which is idiopathic or new CNV, which has been arising, and it is known as neovascular AMD most likely. But CNV can also develop as a result of the retinal pigment, arterial angiomatous proliferation, or due to PCV as well. Both of which are considered to be variant of the neovascular AMD. The prognosis of the untreated CNV is poor, with counting finger vision a common vision a common outcome. So without treatment, the vision is usually counting finger. And understanding of the pathogenesis has improved over recent years. The promotion and inhibition of the blood vessel growth by cytokine is important, particularly vascular endothelial growth factor, which binds to endothelial cell receptor, promoting proliferation and vascular leakage. So VEGF is very important, vascular endothelial growth factor, for the proliferation of the new vessels. The inhibitory mediators, pigment epithelial derived factor PEDF and complement factor H, are also thought to play a key role. Supplementary endothelial progenitor cells are thought to be recruited from the systemic reservoir, enhancing growth of the new vessel complex. So they are inhibitory mediators, which are PEDF. They are also being implemented in the case of the CNV, and also there are endothelial progenitor cells that are also being implemented as enhancing the growth of the new vessel complex. Clinical features include symptoms which consist of acute or subacute painless blurring of vision, usually with metamorphosia. Hemorrhage may give a positive scotoma. So symptoms consist of blurring of vision, and there will be the distortion of images as well. And if there is a hemorrhage, it will give us a positive scotoma. Signs: the CNV itself may be identifiable as a gray, green, or pinkish yellow lesion. So if the CNV is present, it will appear as a gray green membrane lesion on the macula. Associated medium large drusen's is a typical finding in the same or the fellow eye, so there can be drusen's present. Localized subretinal fluid, sometimes with the cystoid macular edema, can be present. So CMO can be present. Intra and subepithelial lipid deposition, sometimes extensive. Hemorrhage is common, which can be subretinal, preretinal, retrohyaloid, or vitreous. Because CNV is a new vessel and it can leak, it can cause a hemorrhage, which can be subretinal, preretinal, retrohyaloid, and vitreous. There may be associated serous fibrovascular drusenoid or hemorrhagic bed. Retinal and subretinal cicatrization, deciform scar is an evolved or treated lesion. So when the CNV resolved, it is converted into deciform scar. So let's see figure 14.37. So this is a sign of a choroidal neovascularization. A is showing a CNV visible as a gray green. submacular area with the surrounding exudation. B is showing extensive lipid deposition. C is showing us a hemorrhage, and D is showing us a deciform scar. Now, what if we do the fluorescent angiography in a case of a CNV? CNV was FA was previously used to diagnose CNV and to plan and monitor the response of the laser photocoagulation or PDT. So first, FA was used. Current indication include diagnosis of the CNV prior to committing anti-VEGF treatment. FA should usually be performed urgently on the basis of a clinical suspicion. So we perform FA before the treatment for the diagnosis of CNV prior to anti-VEGF treatment, and as an adjunct to diagnosis of an alternative form of neovascularization, neovascular AMD such as PCV and RAP. And so second indication is to rule out other causes of neovascularization such as PCV and RAP. Exceptionally, localization of the extrafoveal photocoagulation or guidance for PDT, so it is also used as a guide for PDT. Monitoring is now predominantly with OCT. Terminology used to describe CNV on FA is derived from the macular photocoagulation study, which is known as MPS study. So there are two types. Type 1 is occult CNV and type 2 is the classic CNV. So type 1 is occult CNV is 80% is used to describe CNV when its limit cannot be defined on FA. Variant are fibrovascular PED and late leakage of an undetermined source. OCT manifest as PET, which is commonly multilobulated with variable internal reflectivity. It is present above the Bruch membrane but below the RPE. So it is usually the sub RPE, which is also known as type 1 or occult CNV. So basically the occult CNV, the variant of the occult CNV can be fibrovascular PED. We have discussed in the PED topic that pigment epithelial detachment due to fibrovascular proliferation um, can be considered as an occult CNV, and also a late leakage of an undetermined source. Next is the type 2 classes, which is a subretinal CNV. 20% filled with dye in a well-defined lacy pattern during an early transit, subsequently leaking into the subretinal space over 1 to 2 minutes with late staining of the fibrous tissue. So in a case of a classic CNV, first there will be like a lacy pattern in the early transit phase that will subsequently be leaking into the subretinal space over 1 to 2 minutes with late staining of fibrous tissue. Most CNV is subfoveal, extrafoveal being defined as greater than 200 micrometer from the center of the foveal avascular zone on FA. The OCT shows the subretinal hyperreflective material. It is present below the neurosensory retina but above the RPE. So CNV is usually at the area of the fovea, but how we define it is extrafoveal. Extrafoveal is basically defined when the CNV is greater than 200 micrometer away from the foveal avascular zone, center of the foveal avascular zone. The OCT shows a subretinal hyperreflective material. It is present below the neurosensory retina but above the RPE. So it is between the RPE and the neurosensory retina. So next is the predominantly or minimal classic CNV is present when the classic element is greater than or less than 50% of the total lesion respectively. So if there is predominantly or minimal classic CNV is basically defined when the classic element like classic CNV element is greater than 50%, it is known as a predominantly. If it is less than 50%, it is known as a minimally classic CNV. So let's see figure 17. This is an occult CNV. So you can see type 1 choroidal neovascularization. So there are specks of blood in the at the fovea. B to D is showing us F is showing us a diffuse hyperfluorescence, but the limit of membrane cannot be defined. So like this is a hyperfluorescence and you cannot define the limitation of the membrane. E is showing OCT showing a PET, so this is a pigment epithelial detachment with a variable internal reflectivity and a subretinal fluid. Next is a classic lacy pattern. So you can see in the early transient phase, this is a classic lacy pattern. Classic 2 type 2 subfoveal choroidal neovascularization, A color image showing a gray green area and a small hemorrhage. B is showing early of FA showing glassy hyperfluorescent pattern and an area of a hypofluorescence secondary to hemorrhage. So this is a hyperfluorescence and this is due to hemorrhage. um, C is showing a late venous vein showing more intense hyperfluorescence with leakage and staining, and D is showing us a persistent staining at 10 minutes. OCT is showing us a subretinal. So this is a subretinal hyperreflective material between the RPE and the um, neurosensory retina, and there is a small amount of the subretinal fluid here. So next is indocyanine green angiography. Indocyanine green angiography demonstrate SCNV as a focal hyperfluorescent hotspot or plaque. So in the ICGA, indocyanine green angiography, the CNV will either determine as a hotspot, like there will be the hyperfluorescent very hot spot, and or a plaque. Benefit adjunctive to FA include increased sensitivity in the detection of a CNV, for example, if low density hemorrhage, fluid, or pigment preclude adequate FA visualization. The distinction of the CNV from other conditions that may have a similar presentation, particularly PCV, RAP, or CSR. The delineation of the occult CNV may still have a utility for combined modality treatment and for patients who refuse intravitreal therapy. So these are some of the advantages of the ICGA to find the CNV. So it is helpful in distinction of the CNV from PCV, RAP, CSR, and also for the delineation of the occult CNV. So next is so this is an ICG of the choroidal neovascularization. A is showing blood and fluid at the macula surrounded by hard exudate. B and D is showing us a small area of increasing hyperfluorescence. So there is an increasing area of hyperfluorescence. Next is on the basis of OCT, how the CNV is defined. It is defined as the same. If the CNV is present beneath the RPE, it is known as type 1, and if it is at the subretinal, it is known as type 2. OCT is critical in the diagnosis and quantitative monitoring of the response to the CNV treatment. Typically, CNV is shown as a thickening and fragmentation of a RPE and the choriocapillaries. So there will be the thickening and fragmentation of RPE. Subretinal and sub-RPE fluid, blood, and scarring are demonstrated. Then outer retinal tubulation may be present, often in a branching pseudodendritic conformation. On OCT, the classification is based on the location of the pathology. So type 1 is a occult CNV on offer is above the Brook membrane but below the RPE and manifests as a pigment epithelial detachment that is often multilobulated in appearance. Type 2 classic CNV on FA is below the neurosensory retina but above the retinal pigment epithelium. Subretinal fluid, hemorrhage, or intraretinal fluid may be present. So you can see this is an OCT of the classic CNV. A is showing us a presentation 14.38. So it is showing us a 14.38 and 39. So you can see that here the the membrane is below the RPE, and in this the CNV is in the subretinal space. Next is how do you treat with the anti-VEGF agent. Um, so CNV is usually treated with the anti-VEGF agent principle. Inhibitor of the VEGF block its interaction with the receptor on the endothelial cell surface and so retard or reverse the vascular growth. So basically it blocks the receptors on the endothelial cell, so that is why VEGF do not interact with it and there is a regression or reversal of the vessel growth. They have become the predominant means of treatment for CMV, dramatically improving the visual prognosis. Genetic factors are associated with variability in response, so that visual outcome can differ from patient to patient. Intravitreal injection is the standard method of administration. Notable but rare risks include retinal detachment, damage to lens, RPE tears, and endophthalmitis. So complications include of the intravitreal injections can be RD, damage to the lens, RPE, and endophthalmitis. Sustained elevation of the intraocular pressure and sterile uveitis may occasionally occur. Systemically, there may be a slightly increased incidence of stroke. All available anti-VEGF agents seem to have a potential for benefit in a range of vascular eye disease. As a general principle, the better the visual acuity at the onset of treatment, the better the visual acuity at follow-up. So the more the visual acuity at presentation, the more will be at the follow-up. There is some evidence that younger age at treatment onset may confer a worse outcome. Treatment should be initiated within 2 to 3 weeks of the symptoms onset. So there are many studies that has been conducted for the treatment of the CNV. So they are landmark studies. The following large randomized double masked sham controlled trials provide the evidential basis for the anti-VEGF treatment in the individual with neovascular age related macular degeneration. So first is the Marina. Marina is basically when the CNV is minimally classic or occult, and in that part the anti ranibizumab was given. So this is a Marina study. Minimal classic or occult trial of the anti-VEGF antibody ranibizumab in the treatment of the neovascular AMD shows that a ranibizumab treatment is more likely to prevent visual loss than placebo in patients with the neovascular AMD, a benefit that is sustained for 2 years regardless of gender, age, lesion size, or type. The study also show an improvement in the angiographic and OCT outcome. So basically, in a case of a Marina study, in a Marina study, those CNV which are usually occult or minimal classic was being studied, and when the ranibizumab was given, the outcome was better than the placebo. Then is the Anchor study. Anchor study is the anti-VEGF antibody ranibizumab for the treatment of the predominantly classic choroidal neovascularization in AMD. Confirmed that ranibizumab is more effective than a vortiprofin PDT in respect of the visual acuity, with approximately one third of the subject improving by 15 letters. So Anchor study is now studying the ranibizumab on a predominantly classic CNV, and it is more effective than vortiprofin PDT. Payer concludes that the outcome are better if ranibizumab is injected monthly than if it is injected monthly for 3 months and then 3 monthly for 1 year. So Payer study concluded that the dosage of the ranibizumab. So in a Payer study, it has been concluded if we give monthly injections of ranibizumab, uh, then it is better than if we give a ranibizumab for 3 months and then we after every 3 months for 1 year. Horizon and Sailor studies confirmed that intravitreal ranibizumab has a good safety profile and is well tolerated. Then there is a Pronto study. So Pronto have O, it means that OCT based study. Prospective OCT imaging of the patient with neovascular AMD treated with intraocular ranibizumab shows that OCT guided retreatment strategy result in a similar visual acuity outcome with fewer injections than a monthly schedule. So in a Pronto study, we give treatment OCT guided treatment, and it shows that it is has a similar efficacy as a Payer study, but with the fewer or lesser injections. Harbor studies conclude that a 0.5 milligram versus 2 milligram monthly versus as needed injection of the ranibizumab provides similar results in all the treatment group. So there is a Harbor study proof that there is no difference between the dosage. CAT study, which is a comparison of the age-related macular degeneration treatment trial, compare ranibizumab with bevacizumab intravitreal injections and shows a no significant difference in outcome. So CAT study basically studied the difference between the bevacizumab and ranibizumab, but it showed no difference. IVAN study is basically for the aflibercept. IVAN study alternative treatment to inhibit anti-VEGF in age-related choroidal neovascularization is similar to CAT but uses a dosing schedule of monthly injection for 3 months, then 3 consecutive monthly injection whenever retreatment is required. It shows equivalent visual outcome but finds that arteriothrombotic events and heart failure are more likely to occur in a patient receiving bevacizumab. So it is basically Ivan is basically studying the dosing schedule, and it shows that using a dosing schedule of three monthly injection for 3 months, and then the three consecutive then after three consecutive monthly injection whenever the retreatment is required is having a similar results. View 1 to VEGF trap eye investigation of efficacy and safety in wet AMD shows aflibercept injected bi-monthly is as effective as ranibizumab injected monthly in the treatment of a neovascular AMD. So view 1 and 2 is basically comparing the ranibizumab with the aflibercept. Next is what are the indications of the treatment of anti-VEGF. All CNV subtypes respond to anti-VEGF therapy, but benefit is only likely to in the presence of an active disease. This treatment is of no benefit in patient with mature fibrotic deciform scar. So in the active CNV, it is of benefit, but if the deciform scar has been formed, it is of no benefit. Evidence for active CNV include fluid or hemorrhage, leakage on FA, and enlarging CNV membrane or deteriorating vision, judged likely to be due to CNV activity. So, what are the indications of active CNV? It is there is a fluid or hemorrhage, leakage on FA, if there is an enlarging CNV membrane, deteriorating vision due to CNV. An eye with almost any level of vision may benefit, although better visual acuity at the outset is associated with better final visual acuity. So you can see figure 14.41 is osity of a classic CNV on presentation. B is showing after the 3 anti-VEGF injection showing significant improvement. So there are uh, uh, certain molecules for the treatment of anti-VEGF like aflibercept, ranibizumab, bevacizumab. So first is an aflibercept Eylea, which is a brand name, is a recombinant fusion protein that binds to VEGF-A. So it is a fusion protein recombinant, and it binds to VEGF-A, B, and placental and growth factor. After becoming commercially available, it was adopted rapidly into clinical practice, principally because the recommended maintenance regime consists of a one injection every 2 months. So, in a maintenance regime, it is usually bi-monthly injection. In contrast to the monthly injections recommended with ranibizumab and bevacizumab, though in some patients dosing is required more frequently than every 2 months, the standard dose is 2 milligram in 0.05 ml, as induction of 3 courses is uh, given at a monthly interval. So induction course is usually monthly for 3 months. Then there is a ranibizumab, which is also known as a Lucentis, which is a brand name. Ranibizumab is a humanized monoclonal antibody fragment. So it is a fragment, and it is smaller than a bevacizumab. Developed specifically for the use in the eye, it is derived from the same parent mouse antibody as bevacizumab and non-selectively bind and inhibit all isoforms of VEGF-A. The usual dose is 0.5 milligram in 0.05 ml. Three main treatment strategies are adopted in AMD. First is that there is a regular monthly injection in the regime adopted in initial major dry eye. Overall, around 95% of the patient maintain vision regardless of the lesion type, and 35 to 40% significantly improved more markedly than during the first 3 months. This regime offers a marginally better visual outcome but may be associated with progression to geographic atrophy of slightly greater severity than less intensive administration. There is a suggestion that systemic adverse event may counterintuitively be less common with regular monthly injection than discontinuous schedule. So first is treatment strategy is a regular monthly injections. The next is a 3 initial monthly injection followed by the monthly review of re-injection when deterioration occur as assessed by visual acuity, loss of 5 letters or more, and OCT retinal thickness increase of 100 micrometer or more. So first is that you just give a 3 monthly injection for 3 months, and then you followed it by the visual acuity and OCT. So if there is a decrease in vision for more than 5 letters, and there is an increase in 100 micrometer thickness, you give in the re-injection of 3 injections. Treat and extend entails administering 3 initial injection at monthly interval and then gradually increasing the period between injection until deterioration is evident. If possible, a tailored interval is determined for each patient. So usually in a case of treat and extend is first you treat with 3 monthly and then you start to increase the gap between the injections. Then there is a bevacizumab Avastin. In contrast to ranibizumab, bevacizumab is a complete antibody. So it is not a fragment, it is a complete antibody originally developed to target blood vessel growth in metastatic cancer deposit. Its use for AMD and other indication is off-label. So it is off-label use for the treatment of the AMD. Its use for AMD and other indication is off-label. It is very much cheaper than ranibizumab and aflibercept. Clinical trial results suggest that it is approximately comparable to ranibizumab in efficacy and safety. Although some studies have suggested that the risk of a serious systemic adverse events is marginally higher with bevacizumab than ranibizumab. Treatment strategies in AMD are similar to those for ranibizumab. The dose for bevacizumab is 1.25 milligram in 0.05 ml. Then there is a newer drug which is known as brolucizumab. The drug is significantly smaller than other anti-VEGF agent and has binding affinity. It lasts longer in eye and thus permit less frequent doses. The Hawk and the Harrier studies show non-inferiority to aflibercept with an improved dosing interval. So Hawk and Harrier studies showed that it is non-inferior to aflibercept. Approximately half of the patient on this agent can be maintained on a 3 monthly injection schedule at 1 year. So it is given after the 3 months. Then there is a pagatinib, which is Macugen. Pagatinib sodium was the first anti-VEGF agent approved by regulatory authorities for ocular treatment. The results are similar to outcome with PDT and the use is now extremely limited. Technique of intravitreal injection. Various protocols are in use. A typical approach is set in table 14.3 and applies to anti-VEGF agent. There are slight difference of intravitreal steroid administration. Patient can return to normal activity after 24 hours but should be want to seek advice urgently should they experience any deterioration in the vision or symptoms of inflammation. Tip: in a patient with AMD secondary to CNV, the better the visual acuity at the onset of anti-VEGF treatment, the better the final visual acuity. So next is the treatment with photodynamic therapy or PDT. So first is the line of treatment is anti-VEGF, next is a PDT. So verteporfin is a light activated compound preferentially taken by the dividing cells including a new vascular tissue. It is infused intravenously and then activated by the diode laser to cause the thrombosis. So in the case of a PDT, what you do is you inject the agent verteporfin intravenously and then you activate it with the diode laser. The main indication is subfoveal predominantly classic CNV with a visual acuity of 6 by 60 or better. So it is given in a predominantly classic CNV. Some adverse effects are rare. With advent of the anti-VEGF treatment, PDT is now rarely used for CNV, but the combination therapy and refusal of intravitreal treatment remain indication. Reduced intensity regime have been used with good effect in CSR. Then there is a combination or other experimental therapies that has been going on. Although anti-VEGF therapy has revolutionized the management of CNV, further investigation is attempting to achieve outcomes that are even better, particularly a reduction in the frequency of intravitreal injection. To date, regimes that include a combination of PDT with anti-VEGF agent have not been shown to be superior to anti-VEGF treatment alone. But investigation is ongoing, including parallel inhibition of the anti-VEGF agent with inhibition of other cytokine and low-intensity macular radiotherapy. So first is that anti-VEGF are given with PDT, but it is not shown to have a much benefit with to the treatment. But now other investigations are being carried out, and with anti-VEGF and other inhibitors of cytokines are being used parallelly. Other avenues of potential therapeutic advantages are sustained release anti-VEGF systems and gene therapy utilizing adenoviral vectors to facilitate the production of cytokines within the eye. Next is the laser. Thermal organ or direct laser ablation of the CNV is now rarely used, although may still be suitable for the treatment of the classically small classic extrafoveal membrane well away from the macular center and possibly some cases of PCV and RAP. So now the thermal and diode laser ablation are not being used, but it can be used if the um, CNV is very away from the macula. Next is a hemorrhagic AMD. The visual prognosis for most eyes with extensive subretinal and sub-RPE hemorrhage is poor. So whenever there is a hemorrhage in a case of AMD, it is known as a hemorrhagic AMD. Clinical trials assessing surgical drainage of extensive subretinal or sub-RPE hemorrhage with CNV excision have not shown any significant improvement in prognosis and increased risk rate of a rhegmatogenous retinal detachment. So one clinical trial is basically you just remove the hemorrhage and also the excise the CNV, but it has not shown to have any improvement. Rather, it caused retinal rhegmatogenous retinal detachment. However, better results have been reported using intravitreal anti-VEGF injection and liquefaction of the blood by intravitreal or subretinal requiring vitrectomy. Uh, by intravitreal, uh, recombinant tissue plasminogen activator. So, better results are reported with anti-VEGF agent or intravitreal TPA. In addition, pneumatic displacement may be appropriate for large or thick hemorrhage. If the patient takes coumarin anticoagulant liaison with prescribing physician, is worthwhile to assess if this could be stopped, as there is an association with massive macular hemorrhage. Antiplatelet drugs do not usually require discontinuation, although aspirin may be associated with greater risk of CNV than other agents. Alternative pathologies, for example, PCV macroaneurysm that may be associated with extensive hemorrhage, should always be considered. So this is a technique of the intravitreal anti-VEGF injection. So first, the procedure and tricks should be explained to the patient and appropriate consent obtained. The environment should be appropriate, for example, a dedicated clean room with adequate illumination. The indication and the eye to be treated should be checked and the eye marked. It should be confirmed that anterior and posterior segment examination, including IOP, has been carried out recently to exclude contraindication. Confirmation should be obtained that a syringe of a drug to be injected is available. Bilateral injections are optimally administered at separate session to minimize risk, but if necessary, different instrument and drug batches should be used. A surgical mask should be worn. So it is basically giving us a how to procedure of intravitreal injection, how to give intravitreal injection. Topical anesthetic and mediatic agents are instilled. Povidone, iodine, chlorhexidine, if allergic to iodine, is applied to the ocular surface and at least 3 minutes allowed prior to injection. Some conjunctival lidocaine 1% to 2% may be used to supplement the topical agent. Some practitioners prefer lidocaine gel, though concerns have been expressed regarding the possibility of microaneurysm retention within this. Hands are washed using a standard surgical procedure and sterile gloves don't. The periauricle skin, eyelids, and lashes are cleaned with 5 to 10% povidone iodine. As for other forms of intraocular surgery, a sterile periauricle drape may be advisable. The sterile pouch containing a prepared syringe is open, and or a sterile syringe is used to draw up the appropriate volume of drug from a vial of ready prepared drug. A needle, typically 30 gauge 0.5 inch on the syringe, is primed to expel any air. A sterile speculum is placed in the eye. A patient is instructed to look away